as sir said that the window we had talked before this particular IC, and the window I had given him was exactly very small, and I know that most of the studies which are done in our strabismus have a surgical success of 8 to 10 prisms. So to talk and to think that you can think of treating that small angle was the basic idea behind this particular IC. Whether we can refine our surgical techniques, whether there are any surgical techniques available where we can go, where we can stretch our success rate to beyond the particular thing which is 8 to 10 prism diopters, which is the current standard for strabismus success rate. So what exactly is small? Yesterday I had a free paper on mini-plication. Dr. Hurtle was there, and he asked me that do you think people actually complain? I quoted a patient who came to me for a 10 prism exo, and he was surprised that a 10 prism exo, can patients actually tell that it is the patient has such a deviation. I think patients do appreciate, but as strabismus surgeons, we tell them that this is too small for an angle, and this is not really cosmetically this is not significant. It is significant for the patient, so it is significant enough for us as squint surgeons. The point is whether we have any options for these small angles. So what exactly is an operable angle, and what exactly are the options available? We have gone through the non-surgical options. We know that standard recession resections do not really allow us that limit, do not allow us to go to beyond that particular small limit. So what surgical options are available? This was one paper by Dr. Kenneth Wright. And so what they were doing was they were doing a central tenotomy, and the central tenotomy of 3 mm was performed. And later, when I was talking with one of our colleagues, Dr. Renuka, she was working with Dr. Alan Scott, and I asked her whether there are other people also who are doing this particular procedure. She said that Dr. Scott actually does a lot of partial tenotomies, like he would be doing small tenotomies at the edges rather than the central tenotomy which is being done by Dr. Wright. So it gives a very, very small correction, and the mean correction was, as I am quoting from the paper, it was around, you can see around 1.3 prisms. But this was mainly done for patients who were complaining of diplopia. So this was done for patients who were complaining that they still have diplopia despite having a very, very small angle. And then there was this another paper by Dr. Kenneth Wright and his co-workers where they did mini-plication. So basically what they did was they went 5 mm from the muscle insertion, and they took central 3 mm and took a 3 mm bite and plicated it on the actual muscle insertion. And they had, I think the study had 9 cases. One was exo, and so the surgical success was the surgical success was very. This was actually our study, and this was the patient which I was telling you about at the beginning of my talk. This patient came to us with a complaint of small exo. We know this is a sensory exo, and she said that she wants to get corrected, and I told her that there was this is really small angle. There is nothing much I can do about it. But she kept on saying that whatever small it is, I want to get treated. So, and this is another patient. She had a left eye infraoblique overaction in the left eye. Right eye was already operated a few years back. This patient also had a very small angle. We did infraoblique along with the plication, and this is the post-op result. So this was the average post-op correction that we got out of our 28 patients. In the paper I had described what we got for separate muscles. So we did single muscles. Sometimes, as sir was telling about, when you have horizontal and vertical deviation, you may be having a large horizontal deviation. You can displace the muscles and get rid of the vertical angle. But what if you have only 15 prisms or 18 prisms of exo with 8 prisms of hyper? You cannot transpose the lateral rectus, because you are going to do only lateral rectus, and so you have to do something for the vertical angle. So this particular procedure can help. Adjustable faden was introduced way back, and this was actually introduced by for incommitants in a particular gaze. So I am quoting one of the papers. There are multiple papers on this. This was published by Dr. Nipa and Dr. Rosenbaum. This was published in JPOS 2004. They got a correction of incomitants of 11.6 prism diopters to a post-operative mean of 2.9. So this is not in primary position. This is the primary minus the maximum angle. That is the amount of incomitants patient had. So what they do in this is they resect a part of muscle and then put the muscle on adjustable. So they do a resection and then they do a recession, and this works just like a faden. The advantage is that this has adjustable, and so you can adjust it post-op if at all there is a problem in primary position. So that gives you a good window, because you don't want to go or worsen in primary position. So that is your primary aim, that patient should not worsen from where he is. So if patient has a incomitance in a particular gaze, we can do this particular procedure. We can resect, then recess, and we still have that thing in our hand that we can further adjust it if there is a problem in primary position. So this is just a small video of the same procedure. We have resected it, and then once you resect the muscle, you can do the standard adjustable surgery as you normally do for recessions. So this is how we do adjustable surgery. So you can tie a bow knot, and then you can finally adjust it whenever you want. I think Bupivacaine has been taken care of by Dr. Aloka well, and these are almost same papers which she talked about by Dr. Alan Scott. The Botox with this is how it works, and she has already taken that. And this is the same paper she quoted. And thank you very much. This is all we have. If there are any questions, we can discuss it.